Hello, everyone, and welcome to this session that is a session on teaching health economics. And we have three great presenters today. And we are going to start with Gogo Falia, who is based in India. So I'll pass it over to you now.
Thank you, Heather, and welcome everyone. Hello to my fellow presenters as well. I'm going to share my screen with you in a minute. Meanwhile, I'll give a brief introduction about myself. So I am a primary care physician by profession, and I have recently moved towards health economics and healthcare research. Yeah, so this is where I am at the moment, and I'm looking forward to getting more in depth into health economics and learning from everyone present here. So my topic for today is health economics education in India, the current scenario, the challenges, and opportunities. Now, when we think of India, it's a country of 1.3 billion people with significant healthcare challenges, as you might have noticed during the whole COVID-19 pandemic. Now, one of the most significant factors here is public health, a part of which is health economics. Now, what is the current situation in India? How do things appear? Healthcare spendings in India is 3.1% of GDP, which is significantly lower than BRICS countries and much, much lower when it comes to OECD nations. What is more frightening here is the out-of-pocket expenses, which is around 68%, which is one of the highest in the world. Now, what kind of training do we have here at the moment? Well, in India, health economics are in demand, if I should put it that way. There is a significant shortage of health economists. At the moment in India, what we can see is health economics as a sector has sprouted recently as from like traditional economics. Now, in terms of training, we are severely lacking, which I'm going to show you in the subsequent slides. Positioning in health education. What is unique about health economics is the multidimensional nature of it. It is present in economics, it is present in healthcare, it is present in public health. So when health economics becomes part of all these three sectors, it is difficult to know who basically manages it. Like who is going to take the lead when it comes to health economics training in a country as vast as India. So positioning is a concern. Subsequently, curriculum and learning. Again, as a factor of the multidimensional nature, how do we decide on what kind of curriculum should there be for health economics? What we should remember, specifically in cases of countries like India, like developing countries like China, and countries from the OECD. Every health economic education across the board, we cannot use a single paint brush to paint a picture. What we need to know is country-specific research, country-specific knowledge, which can then be propagated to a broader audience. This is something that India is lacking at the moment. And of course, I mean, we cannot discuss, move to the next slide without the COVID-19 factor. COVID-19 has shown the kind of challenges that the country faces at the moment, and we are going to discuss this further in the subsequent slides. Now, how was this study conducted? A secondary search, internet-based, was conducted of 967 approved universities in India. The approval is done by the University Grants Commission, of which one of the inclusion criteria were economics programs and healthcare programs under universities. One special factor about India is often, in majority of the cases, healthcare is combined into a single university called Universities of Health Sciences. So if there's one state, for example, if there's Maharashtra, which is a state in the west of India, it will have Maharashtra University of Health Sciences. Similarly, For West Bengal, there is a West Bengal University of Health Sciences. Now, exclusion criteria for this study was non-economic and non-healthcare education universities were excluded. That is, universities which are primarily focused on engineering were excluded here, and programs which had single modules were excluded. The reasoning behind this was, in many cases, when it comes to electives, students are much apprehensive and are not much focused when it comes to topic like health economics. For them, it's just an excuse to get a 3.0 or a 3.5 and be done with it. They go home and they forget about it at the end of the term. What did we find in this case? As I previously mentioned, for a nation of 1.3 billion people, there are 3 graduate level programs in India, and certificate level programs are 4. So for a nation of 1.3 billion citizens, we just have 3 programs at graduate level and only 4 certificate level programs, which are not, which of course, as you can see, is not enough. Now, again, let's go to the discussions. Feel free to ask questions at the end, as discussed by Heather. If you have any questions, put it forward and we'll answer at the end. Unidimensional approach, again, in a country like India, which is obsessed with doctors and engineers. If you are not a doctor, you have to be an engineer. Any other education is either frowned upon or is not cared about at all. For example, I'll give you my case. So I am a doctor, as I said, by profession. And when somebody heard, even my schoolmates heard that, oh, so he wants to go into health economics and get into health economic research, the first question was why? Like, what's the need for it? And then the whole topic of why, the importance and everything. So the basic idea for this whole paper comes from there. Again, rigid educational structure. As I previously mentioned, in most cases, healthcare education in India is extremely siloed. So if you are part of clinical research, you usually stay in clinical research. There are no motivations or incentives to move into research, health economic research or research in more public health sectors. If you are a public health specialist, for example, then there are no motives for you to move into any other, for example, in economics-based research or in healthcare management-based research. It is not something which is transformational, which I feel is something extremely important. Meager India-centric research, as I said in the beginning, from my research, in the last 30 years or in the last 3 decades, there have been only 90 papers published, which relates directly to India when it comes to health economics. That is 3 papers per year for a country of 1+ billion people, which, as you can understand, it's not enough. Sociocultural aspects, as I discussed, again, the whole culture needs to change. There is a need for people to understand that health economics is extremely important. Without health economics, the current scenario is not going to change. Recommendations. Now, collaboration and knowledge exchange, for example, what we are doing today, is extremely important. Um, Working together with health economists across the world and in India with a significant learning curve from experienced institutes in developed countries, which have a more mature program and more mature research experience when it comes to health economics, would be extremely useful. Working together with international organizations, for example, the WHO, the World Bank, would be significantly useful as well. Now, for some, it might appear as a negative thing, but for me, as a budding health economist, I think COVID has been a boon for us. It has helped change the attitude of the population, of the people, when it comes to of healthcare. They have seen the situation with their own eyes. They know the kind of expenses, the kind of support that the country needs. So there is a changing attitude of the population, and I think it can be leveraged for further development. Technology incorporation, again, when we are discussing about health economics, like all of us agree that 80 to 90% of global healthcare problems can be solved at a primary care level. Now, at a primary care level, I think incorporating technology is something that can be done with what we have at the moment with the 5G technology and AI. I think there is a significant uh, way that we can incorporate it, even in teaching, what we are doing at the moment, teaching online. Our conference is online at the moment, which is something new. So yeah, technology incorporation is something which can
1
really
minute.
help. Finally, government backing. India's public health picture um, can be described by how India has dealt with situations, for example, when it comes to malaria prevention, when it comes to fighting polio and other diseases. There has been significant backing by the government with localized promotion, centralized promotion, incentivization. So I think why not promote these kind of understanding, promote health economics as a prominent career, show the people, show the interested parties, the students at the school level, that what kind of career you can have, you can achieve by becoming a health economist, how you can contribute to your country's growth, to healthcare needs by becoming a health economist. Thus, I think government-backed promotion, we can easily relate that with increasing GDP expenses. Overall, could appear to be a boon for India's health economics, education, and the scenario that we have today. Thank you, for sorry, limitations. Now again, the pandemic-related constraints
If
was
you could
one of
just
the
finish up, please.
yeah, there was lack of qualitative data here, and financial implications, of course, because the institutions do not have enough money. Future directions, comparative study with BRICS and OECD nations, and need for research on institutional finance along with further education at graduate and postgraduate level. Thank you.
Okay, thank you very much, Gogo. We had one question in the chat. Two questions. So the first one is, what was the methodology of identifying only 90 research papers in health economics for the entire country?
So it was done through secondary research on going through a research journal across the university library papers. There have been previous papers published on this by different researchers who have pointed out that there have been only 90 research papers on health economics per se.
So what were the search terms you used?
Search terms include health economics.
I guess, did you search?
Oh, certainly. Health economics, health outcomes, health planning, India, Millennium 2000, and different institutes, for example, AIMS, Sanjay Gandhi Institute, which is a big institute in India, and other healthcare institutes based in India.
Okay, and then another question from...
So I need to add in a point here. Can I?
Yes, of course you can. Go
Sorry,
ahead.
so if there is time, yes, sure. So I'm pursuing my PhD in health economics. And, we have conducted a systematic review of economic evaluation where only more than 200 economic evaluations only are published for health economics. Leave aside the cost of illness studies and other studies. So the findings by Dr. Felia that only 90 health economic studies have been published is very underreporting. So maybe the methodology needs to be looked into.
Okay, thank you.
Yeah.
Okay.
I think, can I add something?
Yes, of course.
I think one of the factors that that one of our guests have mentioned includes international researchers. My research included only Indian researchers who have undertaken research based out of India. Thank you.
Okay, thanks for that point of clarification. We also have a question from Fricky, who's asked, so how do you see India building the necessary teaching capacity to service more and larger health economics teaching programs? And then there was also that, adding to the previous question, you see government involvement needed to accomplish such a tremendous task? And if so, how do you plan to do it?
I think both the questions are actually related and could be answered in depth, but I'll just give a brief overview. Um, India's polio prevention program has been a resounding success. India is now polio free. It was only achieved by ensuring proper planning and extensive promotion. Now, in a country like India, when we are talking about promoting a topic, even if it's an educational program, the best way to do it is incentivizing. For example, if the country's prime minister or the education minister mentions that we are going to set up an institute of public health and we are going to make sure that COVID-like problems do not occur again, people will surely listen to it. And when people listen to it, they will look for it online, here in different medias. Like in India, there's a radio program by the Prime Minister, which reaches even the most remote areas. So when people hear that the government is doing something, the cynic will see that, wait, is the government doing something negative? Whereas the optimist will think, oh, okay, the government is doing something positive. Let's see what's happening. So education can be done, promoting education, especially health economics, can be done that way. Apart from that, the other question was, oh yeah, the building the necessity teaching capacity is something which is what we are doing at the moment, if we have to be honest, because it is something India cannot do on its own. Indian researchers, along with expertise from across the world, with currently mature programs that we have in the UK, for example, learning lessons from these programs or more academic exchanges can be a way forward towards addressing.
So, thank you very much. Oh, Julie, did you want to come in with something, or are you just turning the camera on? Oh, okay. In the interest of time, we're going to move on to Tommy, and we can always come back to this discussion at the end.
Okay, Heather, do you want me to shoot?
Yes, please.
Yes. Okay, great. Thanks, Heather. And thanks all, and a pleasure to be here to present to you today. And apologies that we can't welcome you here to actually a cold and wet Cape Town, but see you in 2 years, I guess. So today I wanted to present to you some research on looking at the different institutions that are teaching health economics in sub-Saharan Africa. And it gets to see so many who participated actually in this survey on the call, and I'll acknowledge you as I go through, but also to acknowledge my colleagues at the Health Economics Unit who supported this as well, and also the funding from IDSI. I'm currently a senior economist in the World Bank Global Practice, but still affiliated with the HEU through my PhD work, and also this work was conducted while still I was a senior researcher at the Health Economics Unit. So when we first approached this idea, very simple concept of, okay, what is the health economics teaching capacity in sub-Saharan Africa? The first step, of course, was to try and get a better definition. There's a lot of terminology around, and so hopefully this came up with a fairly straightforward list of major topic areas, and we ran this past some colleagues, but it would be good to sort of flesh this out a bit more, and there's been discussion about this in the conference already, but this is probably a subject for another session around what actually constitutes the core topics, but these is what we used, and also this concept of sort of policy translation. So you've got the broad teaching, and then translating these into policy through tools such as decision science, priority setting, and strategic purchasing. It's also worth noting when we talk about defining and identifying health economics teaching in sub-Saharan Africa, that we don't just take a sort of a high income or resource rich approach to what we mean when this definition. And I think we can quite strongly state that the concept of health economics is deeply rooted in the concepts of universal health coverage and how we get there. I've got the Sustainable Development Goals there around universal health coverage, and particularly in sub-Saharan Africa, if we look at those components of universal health coverage, including service coverage, and also financial risk protection. We can see that in many cases, sub-Saharan Africa is an outlier. So there is actually a good argument for saying, while the core elements of health economics are similar, sort of a global norms, but we should take extra cognizance of these concepts related to improving access and financial risk protection in the way that we talk about health economics in sub-Saharan Africa. And then also when we talk about the idea of what does it mean to teach health economics, I think sub-Saharan Africa and many other resource-constrained settings are actually in a kind of a dynamic situation where you've got your formal teaching, but we can't discount the major role of non-institutional type teaching. And I imagine many of us on this call have probably participated or either a recipient or guest lectures on various types of sort of formal courses, informal courses, short courses, or international development partner courses, and these do play a major role, beneficial role on the continent in increasing capacity. What we want to look here at this idea of the formal degree programs, and acknowledging that they're the way to give this strong foundational knowledge in addition to the sort of ad hoc teaching that might occur from these from short courses, important as they may be. So just look briefly on the research aims and methods. So we're fortunate to have Dai's work earlier in 2008, looking at teaching capacity in sub-Saharan Africa. And so we developed a substantive questionnaire distributed in English and French, and acknowledgements to IHEA as well, who hosted the survey on their website and promoted it as well. Also, other colleagues and groups did a lot to promote this and to really try to track down all the different institutions that we could identify. And so from this, we were quite pleased with the 36 institutional responses, and largely we're getting these from sort of course conveners and some sort of administrative staff and everything. We wanted to survey on the basis of institutions as well. So rather than getting multiple responses from the same institution, we wanted to identify by institution and by course. So if you had one institution offering three different courses, for example, a certificate, a diploma, a master's and PhD, you would get three responses there. So mainly master's courses, so 33 of those, and 26 would have the talk component, and then some were research only. We had the one postgraduate diploma from UCT, and then 2 specialist PhD programs. You had institutions offering PhDs with sort of health economics components, but there was only these 2 specialist PhD programs themselves. We're also pleased to see there's a bit of a proliferation in the last few years. So, especially between the last, say, 2016 to 2020, there were 8 courses that came up, and also throughout 2010 as well. So it's good to see this increase in institutions taking it on. Interestingly as well, that for many colleagues it might see, so 2/3 are in public health or schools of medicine. And then very few in say management, and the rest in economics departments as well. So it's interesting to see that sort of focus and sort of the drive around to the public health institutes often taking it up. And it's useful to sort of reflect on that and what that means, and whether we can bolster some of the more specialist economics knowledge as well into the courses. In terms of the assessment routes, observed written examination was the standard. So it was quite interesting, preparing the survey right before sort of COVID was getting going, and then this really had a slant on it, made us sort of interpret these. So if mainly we're relying on these observed written examinations, especially say in University of Cape Town, where we had to switch very quickly to online and online assessments. But this was sort of the pre-COVID type arrangement. So I know many of the institutions would have switched, but it's still insightful to see this large reliance on this form of written examination approach, and then a smattering of other types of sort of oral presentations and practical group work. The course content was actually quite revealing as well. So as we'd expect, health economic theory, you'd hope that would be in all courses, and then economic evaluation, very prominent. Not as much as we would have expected on sort of concepts of macroeconomics and health, and then also applied econometrics and quantitative research. So there was definitely a need I think that they would want to expand that sort of teaching out to the other institutions as well. It wasn't the main focus to look at research collaborations, but we had a few questions in there as well, just to try and pick up some ideas specifically around collaboration within institutions, within countries, and then within sub-Saharan Africa, and then maybe potentially other countries around the world as well. And so there was a bit of a mix there, and especially this intra-institution collaboration was useful to see, and a very small amount, unfortunately, of collaboration with a country not in sub-Saharan Africa. So that was quite rare. And this actually links a bit with some of the existing sort of research. So this is from Panza in 2020 around just looking at cost effectiveness analysis, collaborations within sub-Saharan Africa. And we see the sort of outwards looking research collaboration, and we want to encourage more within sub-Saharan African research as well. A brief touch also on the qualitative results, and this was really interesting to see some of the insights, and it definitely chimed with the experience that we'd had as well. So and it would still be as you'd expect. So the main issues were around sort of funding opportunities for staff development, a lot of this facilitation of research, and then also this idea of the demand for the health economic skills. So there was some comments around where there is the strong policy demand for the health economic skills, this will feed through. But where the health economic skills isn't required or respected by government, this can have a negative effect on the demand for health economics teaching. And then we had some brief ideas around sort of priority areas for development of teaching, research staff, collaborations, and within different institutions as well, and then this new delivery mechanisms for teaching material. We had a few snapshots here around some of the statements, which were quite revealing as well.
One more minute.
So things like institution affiliation fees, and linking teaching to research as well. So all these were really kind of quite insightful. So I'll just quickly finish up with some of these summary teaching needs. So we've got this idea of better definition of what we mean by health economics, get a better profile, acknowledging health economics capacity as a human resources for health issue. I think we'd say if we haven't got enough doctors or midwives to run your health system, we would acknowledge that, and we need to take that same approach for health economists. Better networking, better support. Of course, there's a better funding, and there's lots to talk about previous funding experiences, particularly the HEPNet experience. Better access for students, and then better student output as well. So translating them and developing the students. I've put the information online that you can see. So here's all our courses, and we'll very much be keen to any other courses and institutions that would like to add to the list. Just a plug for the book that's coming out, and there's a chapter on there on teaching in sub-Saharan Africa, and a shout out to my colleagues from the Teaching Economics SIG, and just the acknowledgements there, and once again the enormous support from the Health Economics unit at UCT, and the funding from International Decision Support Initiative. Thanks very much.
Thank you very much, Tommy. So does anyone have any questions for Tommy? Sorry, if you wouldn't mind, stop sharing your screen just so we can see everyone.
Oh yeah, sure. There we go.
Oh, I think I see Arturo and Dai both have their hands up. Arturo, I saw your hand first. Would you like to ask your question first?
Thank you very much. Hi, everybody. Hi, Tommy. I'm from a very underdeveloped country, which is called Argentina. But nowadays, this strange country of Italian in the south, speaking Spanish, we are very happy because we won a football cup. And so Messi, which should be the son of Maradona, is our national hero. And since I'm half Italian, we are also happy about the other game. But just going to the point, I was very much interested about your presentation, and we are doing a very small effort between Argentina and Central America, in terms of starting to have next year a master course in health economics and management dictated with our curricula from Argentina into 3 countries from Central America. So in order, I'm very much interested in trying to get some answer from you in terms of how was your which kind of question do you ask outside of South Africa and to other countries, and which were the answers? Because perhaps in the next future we would like to get in touch with you and with Diane in order to go further. Thank you. Sorry about my Spanish.
No problem. I can respond to that, Heather, if you want.
Beg your pardon?
Yeah, I was just checking with Heather. That's fine. I'll respond. Thank you so much. And yes, we're very happy to share all the information, especially the kind of the survey and the approach to doing it. And it was very useful. The initial background information I presented about what is the health economics, what sort of questions we want to ask, this concept of what is a module, what's a course, that was all very useful. So happy to share that. And we can actually get you in contact with other colleagues in the Teaching Health Economics SIG who are looking at potentially in the future doing some surveys around South America, Central and South America as well. So we'll definitely make that link up. Thank you.
Thank you.
Excellent. Di, did you want to ask your question?
Yes. So Tommy, I mean, thanks very much for the presentation. It was great to see the data. You know, from our experience in the health economics unit, the teaching is so reliant on the research because, you know, it's not feasible in many African countries to get full-time academic teaching posts for health economics. It's just not going to happen. So the teaching was built off the research. So the IHEA started as a research institution, and we felt the need to do teaching activities, to start the master's program, etc. So it's really very closely tied, and I suspect it's quite similar in, you know, to grow health economics teaching in many low and middle income countries. It is going to have to go off that research platform. And then we see the graph that the map that you showed of the links in terms of research. And I don't know if you had an opportunity to attend the Decolonizing Health Economics session, which was excellent, and I would really encourage everyone to watch the recording of it. But it's really a key problem around the funding of research and the power structures within research funding. And although Cara indicated that some of that was changing, until such time as there's more research funding for cross-regional or within the region multi-country studies and sharing of resources, it's going to be quite difficult. So I was wondering if you've done any thinking about about the research funding context within which we find ourselves.
Thanks very much, Diane. And actually, we've discussed these a lot, and I agree with all you're saying there as well. And yes, I purposely wanted to bring that back to the research even though we're looking at teaching. You're absolutely right about sort of nesting this in the research as well. And yes, we've done lots of thinking about it, but I haven't got any major solutions other than that. You know, there needs to be those changes. And I think especially the qualitative survey responses that was coming through hard and fast, that the teachers, that they both to make themselves, you know, they want to produce the material, they want to be good at their teaching job, but then they need the time for the research as well. And there's also that issue of sort of the consulting and things that would come in as well, that researchers are trying to do. Often the funding they could get for research wasn't actually knowledge creation. It was it was fulfilling analytical needs sort of thing. And then the frustration that couldn't really be converted to teaching. So it's really quite complex dynamic, I think. But you're absolutely right, and it's good that we're talking about it as well as to how to get those solutions. But I think the main point of research-led teaching is critical there. Yeah.
Excellent. Thank you very much. And we can come back to this at the end if there's more time. But thank you very much, Tommy, for your presentation. And now we're going to move on to Florian, please.
Thanks, Heather. I try to share my screen. You should see it now. It's fine. Can you see the presentation?
Yep, it's perfect.
Okay. I do not get any information.
Yes, we can see it.
Okay, fine. Okay, thanks. Thanks, and I'm happy to be part of this session on teaching health economics, and my approach is completely different from what we have already heard in this session. My name is Florian Buchner. I'm from the Carinthia University of Applied Sciences in Southern Austria, and I'm happy to present you our health insurance game in its online version. And this is joint work with Simone Flaschberger from the same institution, with Jennifer Cohn, with Jan David Wasem from the University of Applied Sciences in Cologne, and Jürgen Wasem from the University of Duisburg-Essen. I give you a short overview of what I'm going to present you in the next 7 minutes. It's a short introduction. I will give you an idea of the principle of the game. I will show a bit the game in action. I will give you an idea of our experiences so far. I will make some remarks on the didactic background, and I will show it's still work in progress. The whole story began in 2017 in a pre-conference session of the special interest group Teaching Health Economics, organized by Alan Goodman. And some of you may remember when we were playing at least one round and when Jennifer Cohn presented the game and we could play it in person. After that, we tried to adapt the whole game to the Austrian and German environment. And due to the COVID situation, we decided to develop a web-based version. We now played several times, and now 4 years later, we are back on the online conference in 2021. It's not time enough to go into details of the game, but I recommend the chapter in the International Handbook on Teaching Health Economics, which I also highly recommend. We think it's available in October. Coming to the principal idea of the game. There are participants are either consumers with different risk scores between 1 and 6, which represent the probability of getting sick, or they are insurers and have the opportunity to offer health insurance contracts to the consumers. The goal for both is maximizing income at the end of each round and on total. And the course of the game depends a lot on a die roll, which represents the random impact and makes clear whether a consumer gets sick or not. We play normally 4 rounds, which represent different scenarios of health insurance. There is no compulsory health insurance and no guaranteed issue in neither of the scenarios. The first two scenarios are free market scenarios, one with perfect information and the other with asymmetric information. We have a third scenario of community rating. So each and every insurer has to ask the same premium for all, from all his insured. And at last, we have a scenario of risk adjustment, where a pool is paying some money to the insurer for high risk insured, and the insurers have to pay into the pool for low risk insured. So the game in action, we have a web-based form, and there are two different worksheets, one for the consumers, and they may see a sheet like this and get after each round the results. As you may see, there's a regular income, and depending on whether they have insurance or getting sick, they have expenditure. We have also a worksheet for the insurers, which looks like that. And the insurers may offer a health insurance contract to the consumers, and they have to reconfirm the contract and the premium if they want to accept. After each round, we use leaderboards to show the students where they are in the ranking. And we have to emphasize this ranking is a mixture of good calculating premiums and negotiating skillfully on the one hand, and on the other hand, luck with the risk score and luck with the dice. In action, you probably know all the situation of online plenum. For playing this game, it's also necessary to have breakout rooms where the participants can negotiate the premiums, and the instructors may join these negotiations. After having played all 4 rounds, you get a result board. And based on this result board, you can discuss different selection effects like risk selection or adverse selection. You may discuss things like risk aversion and things like that. There's further potential of learning goals we have in this insurance game. There is how to calculate actuarially fair premiums. I already mentioned the selection effects, and you can even go in a deeper learning level if you discuss the different health insurance scenarios with pros and cons, with the risks and the government regulations. Coming to our experiences, most students like this way of teaching and learning. Nevertheless, it's necessary to make clear to students that's not only fun, it's also part of what they have to learn, and so it should be part of a test or an exam. We used the health insurance game so far for beginner students, but probably you can use it as well for more advanced students, and it's very interesting. Effects can be seen even with low sample size. A short remark on the background. I will restrict this to only one of the many potential literature quotations. I will show you a very recent paper of Olga Chernikova and colleagues, and she made a meta-analysis on simulation-based learning in higher education, and based on 145 empirical studies, she came to a large positive overall effect of 0.85, which is very promising for this kind of teaching, and it seems that it's a very effective way. We are still in developing this teaching tool. It's work in progress. We have a lot of ideas. We would like to include more effects like moral hazard, co-insurance or deductibles. We would like to create further scenarios, and we would like to make the game available for teachers from other university and play with student groups from different countries with different health system backgrounds. And on midterm, there's an idea to combine this kind of teaching with some behavioral economics and this kind of research. So coming to the end, unfortunately, we could not play this online game nor in the session, neither at the conference. But there is an alternative. In October, we will have a webinar of the special interest group teaching health economics, and everybody is invited to participate. So save the date. It's October 13th, 2021. And yeah, either you keep being informed by the website of IHEA or you send an email to healthinsurancegame@fh-canton.at. Thanks a lot.
Sorry. Thank you, Florian. Can you please stop sharing your screen so we can see everyone?
Yeah.
She asked, are you teaching economics majors using the game? It seems they would require some other basic training in experimental economics.
Excuse me, could you repeat?
Oh, so is this being taught to economics majors? Just
no,
okay.
It's health economics and healthcare management, and there is no basic knowledge of economics or only a lower level of knowledge in economics.
Okay, thank you. And then Alan asked if there's a manual for this online version. Is that what you're going to be covering in the webinar in October?
Yeah, we probably will play 1 or 2 rounds online to really show how the game works, and yeah.
Excellent. I see a hand from Daniela, if you'd like to.
Yes, thank you for excellent presentation. I would like to know, in the case that this is organized as an examination for the students, I think that it will be interesting to have some kind of criteria for this form. And in the case that there are different universities from different countries who like to play the game, it will be interesting to do a kind of comparison, especially from the perspective what you are presenting, that people have different information about their system in the country and generally. My question was mostly connected, I think, with Alan, if it is a manual for designing and playing the game, if this manual even include or could include in the future some aspects related to examination, and if we could organize after the seminar something related to a plan to use your game and examine students in different countries. Thank you very much.
Okay, that's a lot of questions, and I try to answer that. Yes, we have a manual, but it's in German. So we are in work that we translate this manual, and we hope to have the manual ready to the webinar. But this is only a manual for how to play the game. In the next step, you have to based on the game to teach the people to discuss things like risk aversion or adverse selection. This can be done by every teacher how he likes to do that, but it could be also an idea to develop a manual for doing that. Especially interesting would it to play it with students from different countries and using the same exam questions and comparing the results of these exams. I completely agree, and I think it's a great idea to do that, and we can talk about that in the webinar. I think that's what we like to do with the health insurance game, to bring people from different countries, from different universities together.
Thank you very much. I think that the only question what I had was related to examination, including the game as part of the examination, because gamification, it's a good way of attracting students to play the game, but learning by playing might be also useful. And into that context, I refer to manual and I made my question more complicated. But that I think that is most important, and the aspect of collecting this data using these tools, web survey and our panel of the students and so on. I will be very, very interested to collaborate and contribute if it would be needed. Thank you very much.
Okay, if you are interested in collaboration, so please send an email to our email address, and we answer to that, and perhaps we can do it in a team to develop some further ideas. Thanks a lot.
Gogo, you had a question?
Yeah, I actually had a question for Tommy. I was wondering, like, in terms of assessing health economics program, I saw there's not much when it comes to group work or group presentation. I was wondering what might be the factor, like, did you get any kind of responses, like why there weren't many group work or group programs? Because that is something that I was wondering would be really helpful for students, especially those who come in without a significant background in economics.
Yeah, thanks for that, and definitely. So those figures were like per institution. So, for example, say at UCT, there's a lot of group work. So the institutions that do kind of that type of learning, they do it probably quite well and quite comprehensively. But I guess the setup of the question was simply, identify what types, of learning formats you're in, teaching formats, and it just simply wasn't sort of selected. There was options, for explanations, but we didn't get too much more information on that. So that would be one area that we could explore. But I think just that the reality is that most courses, institutions were just saying, no, it's just, it's a formal sort of evaluation, and not much of those additional sorts of things going on. So that points to the need for, the idea of innovative teaching and all that. But it does link to that narrative of teachers saying that they're under pressure to deliver and everything else, and maybe not time to do lots of innovative course development and all the rest of it. So yeah, so it's my projection, although I don't have the data to back that up, but more investigation, definitely. Thanks.
Florian, there was just a request for you to put the insurance game email address in the chat box as well, if you wouldn't mind doing that. Oh, you're still on mute?
I have already done that.
Oh, sorry, didn't see it.
Thanks.
Excellent, thank you. Does anyone, because we still have about 7-ish minutes, does anyone have any other comments or questions for any of the speakers? Oh, Arturo?
Yes, thank you. This is for Florian. I will write you about the game and ask you if there is any chance that we will do some work from September over in order to introduce some kind of particularities of health economics for people from South America, meaning there are some kind of concept that we went very much in deep into it, and we are very worried about the application of health economics in political solutions for the local government, either for municipal and stuff. So my question should be, is there a chance to do some work together and to do some variation of the game in order to introduce some kind of local characteristics and application of health economics? Thank you.
Arturo, thank you for the question. Two things. We do not have a Spanish version of the game, but that could be another step. I don't. My Spanish is not very good, but I know at least a few words. So I made in Guatemala. So I made some work there. If you are interested to work to put health economics in a political context, I would recommend you to read the chapter in the highly recommended International Handbook on Health Economics. You are a co-author, and there is a chapter on NORICOM, where we try to really simulate political ideas and to develop a new healthcare system in a fantasy country. And I think that makes more sense as an answer to your question than this health insurance game. But we can talk bilateral in the next days about what makes sense.
Daniela, did you have a question?
Yes, it is a short question. I will try not to go into details now. And I think that it is for everyone who presented. It is, actually, I was inspired in the context that health economics used to be taught to students from different fields. And special, for example, when Florian referred to risk aversion, we know that in economics, they already know, at least my students, because I'm teaching students of economics. And into that context, I would like to know if anyone looked into or did some analysis about teaching health economics to different types of students. And especially when it is about the game, to have this, I'm very much interested about this, the importance of basic concepts, and which are actually the basic concepts when teaching health economics. Okay, I don't know if any of you got my question correctly, but I'm mostly interested to know if it's any analysis done into this, what are the basic concepts in health economics, and how, if it is any difference function of the students who are taking the course. Thank you very much.
Okay, would any of you like to quickly answer that? We have about 2 minutes.
Heather, this is Maya Platt, Detroit, Michigan. I maybe might have some recommendation, if I may. Once again, it's to direct people to the handbook on teaching health economics, because there is a chapter there by Professor Femi Ayadi, who very successfully combined teaching, combined using textbook on basic microeconomics principles in her health economics course. So she has some very useful tips and tools in terms of how to introduce basic economic concepts into a health economics course. So please check out that book. It's coming out in September. Thank you.
Excellent. Thank you, Maya. Sorry, I'm muted. I hope that answered your question, Daniela. I know we have 1 minute left, so do any of the presenters, do they have any concluding remarks or anything that they would like to say?
Nothing in particular other than thanks to all those that participated in that survey. The survey is kind of like a one-off thing. It was meant to get something going, right? Not as an individual piece of work. So hoping that spurs more work, more conversations, and everything else like that. That's my final parting remark.
Yeah, I totally agree with Tommy on that. Like we are here to discuss how health economics is taught and can be taught. So it's been really helpful. And from a personal perspective, like I have learned a lot. I mean, this is my first presentation as well. So yeah, and I'm actually looking forward to Florian's game in October. So yeah, that will be cool. Thank you, everyone.
Yes,
Great. Well, I want to thank all the presenters and thank everyone for coming to the session. I hope that everyone enjoyed it, and thank you. Bye.
Great. Thanks so much, Heather, as well. Thank you.
Thanks. Bye. Thanks to Heather.
Thanks all. Bye. Bye.
Bye.
Thank you. Bye-bye.